Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to another episode of Ask the Sports Docs. So we get a lot of questions from our listeners each week, and they're great questions. So rather than responding individually, we thought it would be nice to do these mini episodes where we highlight some of the best questions that we've got and our responses. So let's get started. Hey there, fellow surgeons. It's Dr. Ashley Bassett.
And Dr. Catherine Logan. We're thrilled to share what we think is the next frontier in orthopedics with you.
Absolutely. In our sports medicine practice, we're always looking for innovative ways to enhance our patients' recovery journey.
That's right. And that's why we're excited to talk about accelerated recovery, or XR for short. It's a perioperative recovery supplement that's been a game changer for us.
XR is surgeon formulated with clinically researched ingredients at optimal effective doses. It's designed to support wound healing, prevent muscle loss, and speed up return to functional recovery.
Totally, Ashley. And that's where XR comes in. At my clinic, we've implemented the XR nutritional optimization recommendations as part of our standard of care for patients, and the results have been really exciting.
Absolutely. I recognize that our patients' nutritional status has become an increasingly recognized risk factor for surgery. Malnourished patients face risks like delayed wound healing and infections.
Just recently, I had a high-level athlete I operated on who went through a 3-week XR recovery program. The feedback was really exciting. He had faster healing, minimal muscle loss, and overall a smoother recovery process.
And I had a similar experience. The ease of implementation and the positive impact on patient outcomes have been really motivating to continue to study.
And I tried it too. XR is a cranberry lychee drink mix. It's sugar-free and vegan, and it's safe for anyone over 12 years old.
So, fellow surgeons and healthcare providers, if you're looking to elevate your patient's recovery journey, consider XR. Let's embrace the future of targeted nutritional supplementation together.
Visit xrscience.org or xrscience.org to learn more and join us in revolutionizing perioperative care. Okay, so I have a question from Daniel. He's an orthopedic surgeon. He's based in California. And he basically said, hey, sports docs, I want to know why you use stem cells, or do you use stem cells? So it's a great question. I think Ashley's going to sort of give a little background overview of some of the episodes where we've already talked about this, so you can get a little bit of a deeper dive.
Yeah, absolutely. So I think this is a really hot topic in orthopedics, and one that we, definitely covered a bit in one of our episodes. So we did an entire episode actually on the clinical application of stem cells in orthopedics with a world-renowned expert in this topic, Dr. Scott Rodeo at HSS. So this is episode 43. It was recorded live at the AOSSM annual meeting last year, and it's packed with a lot of useful information on this topic. So definitely go check it out. So I think probably the biggest takeaway for me from that episode was that delivery matters and indication matters. So I think where perhaps we stray as orthopedic surgeons in the community is thinking PRP or stem cells or any of that kind of treatment is going to just be a magic wand, right? Someone has a partial tear of something, meniscus, or rotator cuff, and we're going to inject stem cells and they're going to fix it, right? We know that it doesn't really work that way. We have to have a good delivery system. We have to have a means to keep it there. We have to have a good rehab program to get them better. So I think for me, my indications to use stem cells are the correct pathology. So I really like them for partial rotator cuff tears. I really like them to mild, moderate arthritis that has failed other injections, and patients that are really willing to also undertake the financial risk associated with these stem cell injections, because it is an out-of-pocket cost. So I'm very upfront with people that this could work, this could not work, and that they need to be comfortable with that. But Catherine, what are your thoughts? You take care of a very active population in Colorado. So what are your thoughts on the use of stem cells?
Yeah, I would say I probably spend more time sort of educating people on why I don't think what they're coming in for is the appropriate indication, because
Absolutely.
I think obviously people are trying to avoid surgery, and sometimes something is just like, say, an ACL tear, and I just don't see the utility of PRP in that setting. But I think you hit on sort of some of the most important parts, whereas like there's a lot of confusion where, we really need to make sure a couple things are in alignment. So like our indications are really strong, but then we also have a great delivery method. And then, just where the literature is all over the place is also, there's not a lot of consistency of just the preparation and, what size needle was it? How many injections do you do? Do you let them return to activity after? So I think we have to remember all of those things. And then indications, I think we have pretty similar. For me in my practice, it's generally lateral epicondylitis. I will use it in where I see sometimes now is like patella tendinopathy or partial patella tendon tears that we don't think are on the surgical side. And then osteoarthritis that's not, severe. So more of a mild to moderate for the knee. I'm using it there. Those are probably my majors. But what I'm not doing is, telling people, hey, this is going to regenerate your cartilage. Hey, this is going to repair your meniscus, So I think there's a lot in the market for like even baldness and, like all these other things. So not that I'm an expert in the literature on male pattern baldness, but I don't know how that works. So
exactly. No, I think you're absolutely correct. And I feel like Dr. Rodeo commented on that a lot too, is that like they analyze some of these preparations and some of them have no stem cells, no, mesenchymal stem cells, but they call themselves stem cells. I mean, it's like those IV infusions, like those infusion bars for people that have hangovers. It's like a stem cell injection. It's like, there's no stem cells in that, but they can market it like that. They can kind of say whatever they want. It's an unsanctioned product. So I completely agree with your comment that we need to be educating people. A lot of times I feel like I'm talking people out of spending the $1,000 or whatever it's going to be to get that injection. But I totally agree with the epicondylitis, the patellar tendonitis, and sometimes for meniscus, if it's a big tear that I've done a repair in and the tissue, it's like red, white zone and it looks pretty damaged, but it's a 16-year-old kid and I really wanted to heal. In addition to poking some holes in the intercondylar notch, I'll send them for a PRP just to anything to kind of augment that healing response, right? Yeah. But it drives me nuts when people with meniscus tears that are like flipped like into the gutter and they have pain, or like they get a PRP injection in the community, because that's going to unflip their meniscus and then heal it. It's irresponsible in that regard. Yeah. So I do think we need to be responsible clinicians in how we approach this and what we advise our patients.
Yeah. And we haven't highlighted it before, but Dr. Verma had done a study that came out, I think last summer, with his fellows that also looked at the variability in how much different practices and different types of providers charge for the same thing. So I will try and take that up and post that with it. But I think that's interesting as well, to just really understand there's not even consistency in how much people are charging for the same thing.
Yeah, absolutely. And also like how many, not to belabor this, because I know this is supposed to be short answers, but even like what the protocol is. Like I'll talk to people and they'll be like, oh, I got a set of 5 PRP injection. I was like, why did you get 5? You're like, oh, well, they said it was a series. And I'm like, am I missing something? Am I delayed on the literature? And I look and there's nothing on that. Like we do a single shot PRP injection. There's different levels of the PRP. There's Angel and regular old PRP, as my non-op colleague tells me. But I feel like the number of injections even differs, and there's nothing to guide this. And it costs patients a lot of money to go from 1 to 3 to 5 injections. So that's a very interesting study. I'd be very curious to see that. And we'll definitely post it to our social media as well, too, so you guys can check it out.
For sure.
Awesome. So let's
read that next question, or what do you?
Absolutely. So we'll move on to question 2. So this is from Dan. He's a physical therapist in Maryland and Delaware, because it's that area of the country where you can be a PT in both of those locations. So he asked, what are your thoughts on when to start full range open kinetic chain leg extension post ACL reconstruction? And I feel like this is a perfect question for you, Catherine, given your PT background. So what are your thoughts?
So I have to say, I don't actually have any sort of specific, oh gosh, this is when you're allowed to do it. You can't do it this many weeks. You have to wait for that. I just always, because patients will come in a lot and say, hey, my therapist wants to know if you are okay with this, and I just sort of remind them 2 things. One, like, it's not an extremely functional exercise. So whether I want to see, if you can tolerate it and it feels okay, that's fine. Go ahead and do it. But I really want to see you doing things that are much more functional. So, working into squatting, working into lunging, working into single leg squat, all these sort of things that we do in our daily life, I think are so much more important. And then the other sort of side of it is some people, it's just a very provocative exercise. They just get flared up. They, just get a lot of anterior pain. It just feels like too long of a lever arm for them, and they just don't like it. And it seems to, kind of set them back. So I don't know, I don't have a don't do this until this day, but I never really totally understood the point. I don't know. Do you think any differently?
No, I completely agree. I think like the biggest, the most important thing for me, and especially in the early recovery or even like the midterm recovery, is minimizing strain on the knee and minimizing pain and development of inflammation. Because then there's an effusion, then they lose some motion, then they're walking with an abnormal gait, then that sets them back. And I completely agree. Why do an open kinetic chain quad strengthening when you can do a closed chain on, or even a closed chain under less weight with BFR and do less stress on the knee joint and less pain and less inflammation? So I agree. I don't really have, I was trying to think of like a week cutoff. I don't think I really have a specific time point, but I just think that it's, don't do it unless you absolutely have to. Unless there's like an exercise where like, yep, it needs to be open kinetic chain. Like, I don't really see the need to.
Yeah, like if they can't do weight bearing because of, concomitant procedure, then, we have to be creative. But I think BFR has also opened up so many more options that, we didn't have before. So, before BFR was popular in physical therapy, we were, probably relying, I had that like coffee can in my physical therapy thing and, with the towel around it. And, I just think we have more options now. I don't know.
But we've come a long way.
I'd love to hear, other therapists' feedback. But that also reminds us, we did do this 2-part episode with Candace Townley-Cox. She's a physical therapist in Denver who works in my clinic some days, but also works for a local practice called Evolution. It's episode 34 and 35, and it is, if not the most popular, it's like one of the most popular, highest rated episodes that we've had. So it's been, I think, really helpful. We've gotten a lot of great feedback, and Candace is all about like dropping like a lot of truth. So she did a great job in that episode. So good to reflect back to that one too.
Yeah, we really try to highlight the rehab side of things because it's really important. I always joke with patients, you can be a good patient, I can be a good surgeon, but if you're not going to a good PT and doing the rehab, it's as good as doing a poor job on the surgery, right? Yeah. So it's like, we traumatize the knee and then the PTs save us by getting us through the rehab. So I think it's really important. So definitely check out that episode. It's a great one.
Perfect. Okay, so we did get one more question. This one is actually coming from not one of our patients, but a patient in the community who's seeing another doctor. And they want to know, how do we decide to repair an ACL rather than to reconstruct it? So Ashley, what about you? What do you say?
Yeah, so this is also really a hot topic. So I would say that, and I'd love to hear your opinion on this because I know you've been doing repair for a little bit longer than I have. So I just started doing repair. I do repair augmented with the Bear implant, which we've referenced here before. If you want to hear more about that implant, we did an episode. It was episode 40 with Dr. Sean Anthony, and that was one of the ones we did live at AOSSM last year, talking all about like what is the Bear implant, indications for use, how do you do it, what are the outcomes, all that stuff. But I do a repair with the Bear implant, and I've been doing it for about a year. And so, for me, I'm still very conservative. So for me, it has to be, and I can already hear Sean's ears tingling, it has to be a proximal third ACL with a pretty healthy, sizable stump for me to be able to pass a good amount of suture through and really feel like I get a good hold. And in a patient that, and most importantly to me, that wants a repair. So I talk to everyone about it. And if there's even hesitation, like I had a patient, I was talking to the family, 15-year-old male, and they were very hesitant. They were like, but all of his teammates have gotten the reconstruction with this. And I could tell that's not one that I want to say, hey, let's try this kind of newer technique. So it has to be someone that's really wants to proceed with it, a repairable ACL with a healthy stump. And I really would like young or middle-aged active individuals that may be plagued by graft harvest. So people that are going to be kneeling a lot or have a history of patellofemoral pain or patellar chondromalacia where I don't want to take a PTB. So those are kind of my indications, but I'm curious to hear what yours are, if you're a little bit more aggressive than I, given your experience.
Not. I think, when I started, so it's been a little over 2 years now, when I started, I really just did it with patients who came to me asking for it. So had sort of found, okay, you are trained in this technique. This is what I'm very interested in. And already had done like a little pre-work on it. And we still had that discussion of like, look, this is newer. The data is really strong, but it's newer. And, I think those are the people that are a little bit early adopters and they want to do those sort of things. But even to those people, I talked to them through everything and, continued to follow very happy with the results. So it's basically just part of the conversation. But most important is that they have a good sized stump so that we can get the suture through. It can't be this like all beat up ACL stump. It's just not going to work well. And, I did start with patients who are very, very active, but not teenagers, just because those are high risk people anyway, no matter what we do. And over time, like, I think, my age sort of just dropped as far as like people I was comfortable doing it with. But I think tissue quality is really important. And then the other indication that I have done it, and I think has just been, people have been really happy, is when they have a partial ACL tear. So they sort of are saying, hey, I don't know, it just seems like a lot to go through a whole reconstruction when I have like 50% of my tissue in there. And I think that's a really good option for those people as well. But yeah, I think, I'm still talking, I'm never going to be the extreme of I only do a bare repair or I only do ACL reconstruction. I think it's just like anything, talking to them about quad versus BTB versus hamstring. It's one more tool.
Yeah. I completely agree. Now, I was going to ask you, just curiosity's sake, do you change up your technique for a partial versus if it's a complete tear? I've heard some people do no, okay, because I've heard some people doing like that anchor and to bring it up, but I just feel like it's like, it just makes so much sense doing it with the button and then the internal brace is already incorporated and all of that stuff. So you do the standard way every time.
Yeah, same exact.
Absolutely.
Yay.
Awesome. Great. Well, thank you all for listening to this episode of Ask the Sports Docs. We also want to take a moment to thank all of you, our listeners, for your support. We've been doing this podcast since early 2021, which is crazy when you think about it. It's about to be 2024. It's going to be 3 years. And we're really excited to be watching it grow tremendously since that time. So please keep sending us your questions, comments, ideas. We really love hearing from you. If there's a topic you really are just dying to hear about or a guest you think would be great, reach out to us. We always love hearing about that. So again, if you haven't already, please make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all these things sports medicine. You can also reach us by email at thesportsdocspod@gmail.com. Find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. We really love your feedback. Until next time, see ya.
Bye.